Thank you, sir. Over to you.
Thank you. Narmada can take over, please.
Good evening, everybody. Thank you, Nam. It's been a pleasure to host yet another interesting talk on postgraduate clinic. The education of the postgraduate clinics have been the very priority of our presidential action plan, and we have got excellent people every time for teaching our postgraduates. This when the people from outside states and outside other institution comes and teaches us, it really stays in our mind for a very long time, and there is a large there's a large exchange of knowledge among them. Today we have a very interesting faculty coming from 1 minute. 1 minute.
Yes, ma'am.
Yeah, sorry. Coming from Ramachandra Institute of Research Center, Chennai, Dr. Sai Shri Pradhan, and the postgraduates are from that institute. Along with them, we have Dr. Jeeva Shankar coming from AIMS, New Delhi, which is a very premier institute, along with Sindhu Sivanandan, who is a clinical lead of neonatology at Kaveri Hospital, Chennai. So we have a very good mix of people from the private sector as well as from the government sector. So that, I think, is a very big advantage for our postgraduates. I extremely thank Dr. Kritika for arranging every time non-stop for the past several weeks and several months. Thank you so much, Kritika, for doing that IFBT NSC. So with this, I will hand over to our president, who has clearly planned so much of activity and has taken care of both the postgraduates and the practitioners. Over to you, Dr. Rajendran, sir.
Respected President 2024, Dr. Balashankar, and President-elect Somasundaram, and Vice President Gopal Subramaniam, and Secretary Dr. Narmada, and Rajkumar Treasurer, and Thirumurugan at Academy Coordinator, and Central as well as State EB members. On behalf of IAPT, say welcome one and all. And on behalf of IAPT, say welcome the Sri Ramachandra Institute of Higher Education Research, Chennai postgraduates, and as well as mentor Dr. Sai Sri Pradhan for this program. And in behalf of IAPT, say welcome Dr. Singaravelu sir is a scientific advisor for us. And convener Dr. Kritika is taking meticulously planning all the postgraduate program every week, and she's nicely arranging. And behalf of IAPT, really appreciate Dr. Kritika effort. And I welcome faculties Dr. Jeeva Shankar from AIMS, and as well as Sindhu Sivanandam from the Institute of Kaveri from Chennai. Currently is a lead of neonatology. And behalf of IAPT, say welcome one and all for this.
Dr. Lakshman.
Today's topic is neonate with jaundice. Actually, it's definitely will be useful for the postgraduate DNB as well as MD Pediatric postgraduates. It will be an exam question also. And once again, I thank one and all for this taking this meticulous effort. Thank you.
Thank you so much, Dr. Rajendran. This is one of the most watched program in the IAP YouTube website. So if you go there, the viewership is almost close to about 2,000 for every postgraduate session. So it's been watched over by everybody all over India, and it is greatly benefited by the postgraduate. Thanks to the efforts of the academic coordinator, Dr. Singaravelu, and Dr. Thirumurugan, who had planned this meticulous planning. Now I over to Dr. Singaravelu for his felicitation. Singaravelu, sir. Dr. Singaravelu? Your felicitations.
Hello. Good evening.
Yes,
at the outset, I wish very happy birthday wishes to our President Rajendran. Wish him many more happy returns of the day for his wonderful tenure, what he is making this year. And I am sure that this PG events are really going very well under the coordinator of Professor Dr. Kritika. And I am very happy that people are really learning, and very many PGs are finding all over India very useful. That is why Dr. Devendra Senin and other leaders are also joining Srinivasan sir here. Thank you, Narmada. I wish I don't want to stay in between the academics. Wish you all the best, all the PGs, for a very good learning today under the leadership of the moderator. Thank you.
Yeah.
Thank you for
Thank
giving me this
you.
opportunity.
Thank you so much, Singaravelu sir, as the president, as the candidate for the president-elect. You have been traveling length and breadth of the country, and thank you so much for joining us in spite of your busy schedule. And we wish you all the very best for.
Greetings from Jaipur. Greetings from Jaipur. Thank you.
Dr. Gopal Subramani is there. Dr. Gopal Subramani, please.
Thank you, sir. Respected President, Sir, Secretary, and Treasurer of IAP TNSC. This has been a wonderful program for the past year or so. One of the major events in the Presidential Action Plan. I thank Dr. Singaravelu sir and Dr. Kritika for arranging all these programs, and Thiru for making this a very, very valuable program for the postgraduates. I'm very glad that my son is also in the group watching this program. So I wish the postgraduates happy learning. Thank you.
Thank you so much, Dr. Gopal Subramaniam. Nothing makes us very happy than our children sharing, and we can see the happiness as a dad in your face here. And at the outset, I would also like to congratulate our president, sir, for the birthday wishes. We forgot to wish him at the start. Happy birthday, Dr. Rajendran, sir.
Hello, happy birthday,
Happy
Dr.
birthday.
Rajendran.
Thank you,
Happy birthday, sir.
Just at the correct moment I joined.
Yeah.
Jayendra, you're back in India.
Yeah. Okay. So Dr. Srinivasan sir and Dr. Devendra sir are always with us, and we are also having many elite faculties.
Thank you.
Dr. Tirumurugan sir, our academic coordinator, do you want to add some words to the?
No. I think we should go straight with the program.
Yeah.
So thank you very much. Yeah.
Thank you so much. Kritika, over to you for yet another exciting session of postgraduate clinics. And we have excellent faculty and postgraduate very interested, willing to join. At this outset, I will also request all the postgraduate to please submit their presentations and paper presentation. The last date for that is on July 15, 2025, because we need a whole 1 month to evaluate and give you the results. So please do submit. We have circulated already the link for submission, and the guidelines are present in our website. You can also access our website for the same. So the Congo Pedicon is around 14th, from 14th onwards, and we have the paper presentations and the poster on 16th and 17th. We are expecting a huge number of submissions, and this time, for the first time, we are also having for postgraduates outside Tamil Nadu, we have paper and poster presentation. Please do use this opportunity. They are award papers, and you will be given in the stage for the same. So with this, I will hand over to Dr. Kritika, and please do spread the word about our paper presentation all over to your institutes also.
Yes, ma'am. Yes, ma'am. So, good evening, ma'am. Thank you, ma'am. Respected Rajendran sir, respected Balashankar sir, respected Somasundaram sir, respected Gopal sir, dear Narmada ma'am, Rajkumar sir, and Thiru sir, and respected Singaravelu sir, warm welcome. This is our 7th program of IAP PG Masterclass, and 2 learners from Sri Ramachandra Institute of Higher Education and Research will be presenting a case of neonatal jaundice today under the skillful mentorship of Dr. Saishri Pradhan, who is the Assistant Professor of Neonatology in Srihar, Chennai. And I'm really thrilled to announce the faculties today. Excellent and eminent faculty from the Premier Institute. Dr. Jeeva Shankar sir will be the lead faculty. And sir is a professor of Department of Pediatrics in AIIMS, New Delhi. And sir is a lead of a multi-institutional program on neonatal sepsis. And he is a key contributor to 8 global WHO guidelines on newborn health. And he has been featured in the top 2% of scientists across all scientific fields based on the ranking using citations in 2021, 2022, and 2023. And I pursued undergraduation and CRRI in the Institute of Child Health, Madurai, under the able guidance of Dr. Jeeva Shankar sir. Jeeva Shankar sir was a postgraduate, and I was doing my PG and internship. Sir is a great teacher even then. And the second faculty is none other than my friend, Dr. Sindhu Sivanandan, who is a clinical lead of neonatology in the Kaveri Hospital, Chennai. And she's a key contributor of various NNF guidelines. And welcome, Jeeva Shankar sir, and welcome, Sindhu. And thank you so much for accepting our invite and being the faculty with us today. Thank you so much. And Dr. Shiva will be presenting the case. And over to you, Shiva. You can share your presentation.
Good evening, sir. Good evening, ma'am. I would like to thank all the IAP.
Excuse me, Shiva, 1 minute. So we will be, Shiva will be presenting a case for the next 60 to 70 minutes. And it will be like a university case presentation. And at the end, for 15 to 20 minutes, Dr. Sindhu will be presenting a short lecture on how to approach a case of neonatal jaundice. Thank you. Sorry for the interruption, Shiva. Please carry on.
I would like to thank the IAP Tamil Nadu State Chapter faculties for giving me this wonderful opportunity. And I would like to convey my gratitude to Dr. Saishri ma'am for giving me this opportunity to present in this huge forum. Myself, Dr. Shiva, doing final year pediatric final year resident in Sri Ramachandra Institute of Higher Education Research, ma'am. And this is.
Good evening, everyone. I'm Dr. Shruti, doing final year pediatrics in Sri Ramachandra Institute. And I would like to convey my wishes. Happy birthday to sir. And
Happy birthday, sir.
Thank you. Thank you. Thank you. Thank you.
Sir, shall we move on to the presentation, ma'am, sir?
Yes, ma'am. Yes, ma'am. Yes, ma'am. You can share your PPT, ma'am.
How much time do we have?
Sir?
How much time do we have for the discussion?
We have about 1.5 hours.
70 minutes. We can go on.
You can go on, sir. 1.5 hours is there.
Go on.
Till 9:30, so.
You are very eager to run, sir. You can go on.
Ma'am, is the slides visible, ma'am?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Go to the slideshow, ma'am.
Yes, ma'am.
Yes, ma'am.
I would like to present my case. So this is baby X, who is male baby, term 37 weeks plus 5 days, currently 6 days of life, born to a 26-year-old primary mother, delivered by emergency LSCS in view of fetal bradycardia, admitted to NICU at 20 hours of life due to yellowish discoloration of skin up to thighs was noted. So date of birth of the baby was 26/6/2025, 12:12 p.m. The date of examination was 2/7/2025. So moving on to the maternal details, mother aged 25 years and father aged 30 years. When they both got married, mother conceived at 26 years, which was spontaneous conception. First trimester pregnancy detected at 1.5 months by urine pregnancy test after missing periods, and which was confirmed by the ultrasound. Booked at Kottapakam GH and was on regular antenatal checkups. Pre-pregnancy weight was 58 kgs, and the weight gain during pregnancy was 9 kgs, which was found to be adequate. The mother took folic acid tablets regularly after conception. Mother blood group was O positive, and the initial blood test, which was done during the initial visits, was told to be normal. There's no history of any fever, rash, drug intake, or any spotting TB. Second trimester, quickening felt at 5th month of gestation. 2 doses of TD vaccines was taken by the mother. Iron and calcium tablets were taken regularly. Anatomy scan done, and mother was told it's normal. No history of gestational diabetes mellitus, pregnancy-induced hypertension, or any other thyroid disorders in the mother. There's no history of any itching or yellowish discoloration of the skin in the mother during pregnancy. So third trimester, mother continued to perceive fetal movements well. No history of gestational diabetes mellitus, PAH, or bleeding TB or leaking TB. Growth scan done and was told that baby was gaining weight appropriate for age. So natal history, mother developed a labor pain on 25/6/25 around 10 p.m. and on the same day, the mother was admitted in SRMs. Continuous fetal monitoring was done. 14 hours later, mother was taken up for LSCS in view of fetal bradycardia, and baby was delivered at 12:12 p.m. on the next day, 26/6/25. Baby cried immediately after birth with a birth weight of 2.62 kgs. Early initiation of breastfeeding was done in OT, and baby was shifted to ward. So postnatal history, baby was continued on exclusive breastfeeding, and baby was initially sucking well, passed urine and meconium within 24 hours. Weight loss noted was 3%. The weight on day 1 was 2.54. At 20 hours of life, baby was found to be till thighs, otherwise feeding well and has normal activity. Transcutaneous bilirubin meter done was high, and the corresponding total serum bilirubin values were sent, which was our phototherapy cutoff. The mother was counseled the need for intensive phototherapy due to blood group mismatch. There is no history of high-colored urine or staining of diaper, no history of passing pale-colored stools, no history of irritable cry, seizures, or any posturing. The child is sucking well. There is no complaints of reduced activity. No swelling over the scalp noted or any instrumental delivery history was there. So treatment history, baby was shifted to NICU and started on 888 phototherapy. Baby required phototherapy for 4 days. Quality feeding was continued even during NICU stay. Serial bilirubin levels were done and TLPT initially changed to DLPT on day 2, and which was changed to single-leg phototherapy on day 3 and stopped. And baby was shifted to ward. The mother's blood group was O positive, father's was A positive. Baby's blood group also found to be A positive. The rebound bilirubin that was found to be normal. At present, day of life is 6. Baby is off phototherapy since yesterday on exclusive DB of sucking well, feeding 10 to 12 times per day, each feed lasting for 10 to 15 minutes, and then letdown reflex is present. Mother needs assistance on holding and feeding the baby, but baby is passing urine 6 to 8 times per day. Current weight of baby is 2.44 kgs and weight loss is 6.8% on day 6 of life. Immunization history, BCG, hepatitis B vaccine, OPV were given on the same day of birth. This is the firstborn child to non-consanguineous marriage. There is no family history of any jaundice, blood transfusion, neonatal death, or any gallstones. Socioeconomic history, father educated up to 12th standard, working as an electrician. Mother's education is BSc Computer Science, currently homemaker. It is a nuclear family, stays in a Pakka house. They belong to lower middle class, according to the modified People's scale. So this was the history which was noted. Shall we move on to examination, ma'am, sir?
Let us stop here. You can go back to the first or second slide. Okay. Fine. Next. Okay, so I will keep it up. We'll not discuss much about jaundice. I will talk about jaundice and then as required. But let us keep this class predominantly to newborn case presentation. Okay, so basics of newborn case presentation. So let us start from the very basics. So why you start from maternal details? Why a newborn case? You're presenting a very different.
Yes. The age of conception is important in case of mothers. In case of elderly preemie, there are more chances of congenital anomalies, and Down syndrome is more prominent if the mother is conceived more than 30 years of age. And if the mother is conceiving, it's a very at the age less than 20 or less than that, the probability of getting small, just low birth weight babies are more prevalent.
No, my question was a little different. Why we have to ask the previous obstetric history or maternal obstetric history? Why do we go from there? What is the importance of previous obstetric history, for example? Here it is mother's a preemie, but why do we ask that question?
Sir, in case of previous, we can look for any, in case of previous baby having any congenital previous abortions, there is a recurrent chance of abortion in the next trimester.
But here the baby is born.
Yes.
So I think the most important part, whether it's an MD or fellow or a DM, so most important thing is for every aspect which you're asking in history, as well as in the examination, you should know why we are asking that question, as well as why we are doing that. Okay. So why previous obstetric history is important? Yes, at least you should be able to list 2 or 3 issues which are relevant in this baby, and now you have the history of something in the previous sibling. Okay, here it's not possibly relevant because of the triangle, but still you should know why we are asking previous obstetric history. Okay, so anything that comes to your mind? Conditions that can recur in subsequent pregnancies?
Any sudden neonatal death in the previous pregnancy may indicate some inborn error.
Okay, so more than sudden infant death, it will be like history of lethargy or sudden, maybe after 3 or 4 days, maybe lethargy, vomiting, and something to suggest a metabolic disorder. So why we ask about inborn metabolism? Because these conditions are?
Most of the inborn errors of metabolism are autosomal recessive.
So there is what is the recurrence risk in the next pregnancy?
25% of
25%. So there is a chance. The 1 in 4 chance that the next pregnancy. So you have to be aware. Okay, so the previous pregnancy, something is something which is suspecting an inborn of metabolism. So there is a risk in the next pregnancy. 1. Anything else? Why previous pregnancy details are important?
So in case previous pregnancy, the child had a need for phototherapy or any history of jaundice,
Very good.
this baby has a higher risk of again getting neonatal hyperbilirubinemia, which may require phototherapy.
Yeah, so that's important, particularly in this case when the baby is actually presented with jaundice. So I think that's an important history. So, and particularly RH isomerization. So the severity subsequent pregnancy is going to increase unless we intervene. So that's important. So previous pregnancy has a baby who had actually required exchange transfusion. So I'll be doubly careful or triply careful whether I might think of even shifting the basic if the baby requires based on the cord bilirubin and cord the test. So that's important. Okay. So on is RHS, one is important metabolism. Anything else? Which you should be aware and why that should not be missed. So one more thing which should not which has implications in the newborn period is previous pregnant say has a baby in which you're suspecting a primary immunodeficiency. Okay, for example, this of course is quite rare, but you should not miss this. For example, a previous pregnancy in which a baby had a primary immunodeficiency, particularly SCID. So the next pregnancy, you're suspecting something can happen. If antibiotic investigations were not done, then you might delay immunization. You might have to delay immunization till you rule out that. Okay, so previous history is important. Okay, and that's why we are starting from there. And of course, the other issues like whether the previous child is thriving or not, whether the parents are able to take care of the baby or not, that's also important. And there are some conditions which are not sort of a recurrent, but there's a possibility. So previous history of preterm birth, this baby is likely to be preterm. Previous history of low birth weight, there is an increased risk of low birth weight. Okay, so that's why we ask.
Cyanotic or acyanotic congenital heart disease, the more chance of getting cyanotic congenital heart disease in the next
what are the what are the increased means how much the risk is increased? What is the magnitude of increased risk if the previous child had a congenital heart disease? Go and read. Okay. So I think means if you tell something, then you should be able to substantiate that. Okay. So that's important. So whether this is whether the recurrence risk is more with the congenital heart disease or with the acyanotic heart disease, with cyanotic heart disease or acyanotic heart disease, and within acyanotic heart disease, whether it is for obstructive lesions or for shunt lesions. So you should know what is the recurrence risk in the subsequent pregnancy. Okay. So that's the first one. Second, you asked mother considered 26 years, which is spontaneous conception. Why is that important? Spontaneous conception or whether the child, the baby is born because of assisted technology.
In case,
so how does it matter to us?
So in case if the mother is having some infertility issues and they are taking alternative ways of getting pregnancy, the more chances of a twin pregnancy are common, sir. In case the twin pregnancies are there, more chance of preterm delivery and twin pregnancy related complications are higher, sir.
Okay, good. Yeah, that's one. So one is, of course, multiple gestations. And second is the complications related to that. So but what about singleton? If it's only singleton, assisted reproductive technology, versus singleton born by in a mother who had just spontaneous conception. So is there any difference in terms of immediate outcomes or long-term outcomes? Okay, so that's again why we are asking about spontaneous conception. So we should know what's the difference between a baby born by spontaneous conception versus a baby born by assisted reproductive technology. Okay, so you should know about the risk of spontaneous prematurity versus induced prematurity in these babies, even in singletons. Forget about the multiple gestation. Then we also should also know about any risk of malformations. Okay, and risk of malformations, whether they are increased in case of babies born through assisted reproductive technology. Then you should know the risk of any developmental abnormalities. Okay, so neurodevelopmental outcomes, adverse neurodevelopmental outcomes, whether they are increased or not. So that you should know. Okay, so that's one. Now moving on to the first trimester. Okay, now how does it matter whether you did a urine pregnancy detection 2.5 months by urine pregnancy test? Does it matter? Baby is born. Now baby has jaundice. So why this history is important?
So the early initiation of ideally that if we ideally folic acid tablets should be taken pre-conception. So if there is a delay in detecting pregnancy, there is a delay in taking folic acid, and
But by the time you detect by urine pregnancy test, actually the organogenesis would have been complete. So very unlikely that is going to help. But I think most important is it's not about whether you detected by urine pregnancy test but most important is whether first trimester ultrasound has been done and when was that done. Okay. So the first trimester ultrasound done within the first 9 weeks or 8 weeks. So that's likely to be the more accurate reliable estimate of the gestational age. So particularly when I'm not very sure about the dates, the mother is not very sure about the LMP, and therefore I'm not sure about the expected date of delivery. Therefore, I'm not sure about the gestation. So because this way particularly, jaundice, you have to use the phototherapy cutoffs, and then you are going to base your phototherapy cutoffs based on the age in hours, but also based on the gestation. So accurate estimation of gestation becomes crucially important. So you have to know whether the dating ultrasound was done. So confirmed by ultrasound, more than important is that whether the date was confirmed. Okay, so that's important. So when they say that is on weeks, I should know that actually that is on weeks, and also confirmed by a first trimester ultrasound closer to a detection of pregnancy. So that's important. So that's why we are asking that question. Okay. Pre-pregnancy weight. So weight gain during pregnancy of 9 kg. What do you think? What do you make of this information? Is it appropriate? Is it optimal? Is it suboptimal?
So the weight gain during pregnancy, it should be based on the mother's BMI.
Yeah, good.
If the mother is obese, she should only gain of 5 to 8 kgs will be adequate. So if the mother is very thin, if the BMI is less than 19, then ideal weight gain should be of more than 11 to 14, sir. This mother BMI is found to be normal, sir. Hence, the pregnancy weight gain was found to be adequate, 9 kgs.
Okay. So, fine. That's good. Anything else here? Mother's blood group is more positive. So, it's fine. So, that has implications in this particular baby. We'll come to that later. So, fever with rash and other things, we can just skip that. Next. Quickening felt film gestation. Why is this history important?
But in case of spinal muscular atrophy or any neuromuscular disorders, the quickening will be felt very late by the mother, sir. But in this case, the mother is a preemie, so she won't have that. It will be difficult for her to.
She may not be able to compare with the previous pregnancy, but still, if the quickening is delayed, or she means by talking to other women or relatives, she will know that okay, there was some reduced fetal movement. So there is implications. Possibly there's not this history is not relevant to this baby, but for completion's sake, you're taking this fine. So TP, iron and calcium, anomaly scan. So fine. Anything else? So itching or yellowish discoloration of skin during pregnancy. Why is that history important?
It starts as history to rule out any intrahepatic cholestasis of pregnancy, sir. If the mother is found to have intrahepatic cholestasis of pregnancy, there is a chance of baby developing PFIC, progressive familial intrahepatic cholestasis.
Okay. Anything else apart from PFIC is of course quite rare. Anything else which has implications for the baby? So if a mother has intrahepatic cholestasis of pregnancy, one thing there is actually increased risk of intrauterine death. Of course, here the baby is born, so that is not applicable here. So one is intrauterine death. Okay, so there is sudden there is association, but there is definitely an association of increased intrauterine death. One. Second, there is also an increased association of babies born through meconium stained liquor. Okay, so the liquor is likely to be meconium stained. Okay, now there is high risk. I won't say that it's likely. There's a slightly higher risk of meconium stained liquor in the mother has intrahepatic cholestasis. So you have to be ready for that. Okay, so that's again, so you are asking that history. Okay, next. So GDM and pH, you can ask the second trimester itself. You don't have to wait for the third trimester. And bleeding PV, leaking PV. So leaking PV, I hope you will be able to explain why you're asking history of leaking PV.
Maybe during towards the third trimester of the class and half.
Sorry, I'm not able to hear. Can you be a little bit loud?
For leaking PV, premature rupture of membranes 4 amniotic.
UTA, chance of getting UTA and premature rupture of membranes will lead to chorioamnionitis and subsequently sepsis in the newborn.
Okay, fine. Okay. And growth scan, again, you're talking about the second trimester, typically. Means growth scan. Okay, fine. Okay, sorry. I thought anomaly scan. Fine. Next. Second. Next slide. Okay. Labor pain and around 10 p.m. and continuous fetal monitoring. Is it required in all the pregnancies? How do you monitor during intrapartum period? What are the WHO recommendations for fetal monitoring during pregnancy, during labor? Sorry.
G.
There are WHO recommendations for care during intrapartum period and care during the antenatal period. So go through the recommendations. I think that it will be helpful. Okay. So you should know whether continuous fetal monitoring is required in normal pregnancy, not in a high risk pregnancy. And if what actually the recommendations are, you should know that. So now what is the normal duration of labor?
In case of primary, it differs from the primary mother and if a mother is having previous pregnancy. So usually it is 12 hours duration, 12 to 14 hours for primary mother. In case of previous delivery, it is usually less than that.
You're talking about all the stages of labor? Or talking about some?
No, sir. Onset of labor, friend, and to the point where the delivery happens.
So that's basically you are saying about the first plus second stage. So again, you should know how first stage is. So basically, it's not like that. So you should know first stage is itself classified into two. There's a latent phase and there's an active first stage, and then second stage. So you should know the duration, optimal duration. I mean, not the optimal, but what is the maximum duration which is recommended for active first stage, latent stage, as well as for the second stage. Okay. Again, for primary and for multi. So you should be able to. So when you're asking this history is particularly important, and this history of when the baby has actually history of asphyxia. That because this history is crucial. So for every case, newborn case, then you should know which are the things which I'm going to highlight. So the preterm, 32 or 33 weeks, then I am going to ask. So in the antenatal period, you didn't ask about antenatal rights, which is perfectly fine because it's a term baby. But in a preterm baby, then I would not, means if you don't ask that history, then that is it's not acceptable. Same way, asphyxia baby, duration of labor, any assistance during labor, monitoring was done or not. So all those things has to be detailed. They have to be detailed. Similarly, in jaundice, so you should know what are the things that can. So for example, one of the not risk factor, one of the associations previously it was just thought to be, but not as thing is oxytocin during labor. Okay, as well as there are some associations with other things also, like epidural and other things. So you should know what the current status is, whether there is any association between, for example, intrapartum oxytocin. That is, we are talking about not third stage, we're talking about first stage, which itself is whether it is recommended or not. You should know. Okay, so you should know. Okay, for jaundice, I should know these specific questions. For asphyxia, these specific questions. For preterm, these specific questions I should ask. For IUGR, I'm going to ask these specific questions. So you should know these questions, which are crucial for each case, as well as the generic questions. So generic questions, you can just go fast, but the specific questions for that particular case, then you should be elaborating on that. Okay, so that's important. So here, then you should know whether there is possibly for jaundice, it's not possibly that relevant, but it's still important to ask about monitoring and ask about the duration of a stage, duration of this thing. If the mother doesn't know, then you should at least know, okay, from the time of painful uterine contractions till the time of release. So combined first and second stage is this much, and that's what actually is more than or less than what actually the WHO recommendation is. So you should be able to know that. Okay, fine. So cried immediately after birth, early initiation of breastfeeding is fine. Fine, that's fine. Okay. Next. Okay, on excessive breastfeeding and maybe a second well. Okay. Okay, TCD was done and mother was counseled for informed that need to recruit business. Okay, so apart from blood group, what else? What other investigations were done? Baby's blood group was done, which is just A positive, as I understand. What other investigations were done?
So other investigation based in complete blood count and direct Coombs test was done, sir, and peripheral smear was done.
Okay, so you'll talk about that in the examination, findings, those results of those tests?
So we'll discuss now, sir. Complete blood count has been done to look for the baseline hemoglobin and to follow up on the any drop in hemoglobin in case of any hemolysis noted, sir. And DCT, direct Coombs test, was done to found out any autoantibodies are present in the RPCs, which could be ongoing hemolysis, it could indicate, sir. And peripheral smear, in case of OA incompatibility, microspherocytes can be appreciated. And in case of congenital hereditary spherocytosis, spherocytes can be found out, sir.
Okay, in this baby, what are the findings?
In case of even of a G6PD, we can find out Haynes bodies and schistosomes.
Okay, but in this particular baby, what were the findings?
In peripheral smear, it was found to be only normal, sir, neutrophilic leukocytosis. So
okay, and what about the Coombs test?
DCT was found to be positive.
Positive. Okay, so can we have an ABO incompatibility when baby develops jaundice and without having a positive DCT or Coombs test?
Still, it is possible, sir. Possibility of DCT negative and still ABO incompatibility is possible.
Any other? What do you think of the other?
In case of minor blood group like Kelly's, still there is possibility of incompatibilities.
Okay, so that's the traditional teaching has been that even without direct Coombs test, because the direct Coombs test is likely to be negative even in some cases of the ABO incompatibility, and that's why we didn't rely much. But I think the current thinking, and I think you can. There is one article published in Journal of Perinatology 2023, so which has a very good review on ABO incompatibility. And the author actually sort of argues against clubbing all those babies who are in which there is ABO incompatibility, in the sense that mother is O and the baby is either A or B. And if the DCT is negative, Coombs is negative, but still calling them as ABO incompatibility. So he argues that that's not the correct way. DCT has to be positive. So that's what his argument. Not universally accepted. Still, many people believe that the old system, the old way of teaching is still acceptable. But you should know the controversies. That at least there is evidence to show that those who have the babies in which DCT was positive, those babies are likely to have much higher, more severe hyperbilirubinemia, and the need for phototherapy and exit transfusion is likely to be higher than those babies who are negative DCT. So whether that's ABO incompatibility, if there is no negative DCT, is a question mark. The controversial, but it seems that possibly people are now moving towards this direction, that like in RH isomerization, we need a DCT to be positive. The same way, it seems that people are moving towards that direction, even in ABO incompatibility. So you should know that. Okay. High color during shining of diapers. So you don't expect in 20 hours. So you don't expect direct bilirubin to be manifesting by that time. So of course, for completion's sake, you can ask for pale colored shoots and eye color, but I don't expect that history by 20 hours of life. Okay, so very unlikely that direct bilirubin will be so high, and then that will manifest by that time. So very unlikely. So you can at 20 hours you can skip these high colored urine and passing pale colored shoots. You can skip that. I would expected this history in a baby who is presenting having jaundice even after 2 weeks, or even after a week. Then I might ask this question, but not at 20 hours. Okay, irritable cry, seizures, posturing. Why you're asking this? Why you're asking these signs for these signs?
The child had jaundice. We would like to rule out the acute bilirubin encephalopathy features.
Okay, fine. So what are the stages of acute bilirubin encephalopathy?
So it is divided into early, intermediate, and advanced, sir. And we can assess by bind score, sir. The bind score has a component of mental status, muscle tone, and cry of the baby. That is a grading till score of 9, sir. 0 to 3 is taken as mild encephalopathy, which is usually reversible. And stage 2 is 4 to 7, sir. And severe is more than 7 till 9. which cannot be reversible, which needs immediate.
Okay, good. Go ahead. Okay, no post-surgery activity. Fine. Swelling of scalp for?
So this was asked to rule out any caput succidium, cephalomyopathy, or any subgaleal bleed, which can predispose to prolonged jaundice and rise of
does
increased
caput also
fear.
does caput also increase the risk of hyperbole?
In case of
okay, instrumental delivery, you should ask in the neonatal history. Okay, so you don't know here. Fine. We were shifted to NICU and started on triple light. So, what is the recommendation? The recommendation for babies who require phototherapy? For phototherapy.
Yes, sir. So since this baby is 37 weeks plus 5 days, we'll be following AAP 2022 bilirubin chart, sir. In the chart, it has been added 3 charts will be there. So one is phototherapy range and escalation and the exchange transfusion range, sir. Since it is near the escalation range, and we have started on a triple light phototherapy, sir.
We started on what? Sorry, I missed it.
A triple light phototherapy, sir.
What do you mean by triple light phototherapy?
Sir, we'll be using phototherapy using 3 LED lights, sir.
So the recommendation is intensive phototherapy. And what is the definition of intensive phototherapy? If you read the 2022 guidelines, even 2004 guidelines clearly mention what is intensive phototherapy. So that should be minimum, at least a spectral irradiance of at least 30 microwatts per centimeter square per nanometer. So that's important. Okay. So whether you achieve that 30 microwatt, that spectral irradiance by single light or double light, or that's material. So you should 2 things. One, you should make sure that the irradiance is adequate, at least 30. Okay, and usually there is a as you increase the irradiance, then the rise of the clearance rate also increases. But there is some plateauing after. It depends upon this thing. So usually after a particular level, there is some plateauing. It might not increase further. So there is only limited gain. So, but more than 30, every baby requiring phototherapy should receive that. Okay, that's important. So it doesn't matter whether it's a triple light. But second is the surface area. One is irradiance, second is surface area. Baby surface area, how much is exposed to the phototherapy? So you can have 50 microwatt or 60 or 80, but the baby is only the surface area exposed is very minimal. In that case, again, you're not going to actually achieve the bilirubin clearance. So you should make sure that, so what more important would be that whether the baby's, all the surfaces are covered or not. I think that's more important. So don't focus on triple light or double light. That's not important. The issue is that whether we received intensive phototherapy or not. Okay, and if intensive phototherapy, so you should be able to, even if, for example, every unit should have a flux meter, and the flux meter should measure the irradiance, and then should, okay, so, and it should not be measuring only at the baby's, where the baby's, the tummy is, at the peripheries as well. Okay, so the babies, for example, the hand, the soles, they are also should be receiving at least 30 microwatts. So that's important. Okay, so so you should know what's the definition of intensive phototherapy, and for example, you should also talk about the height of the equipment.
Recommendation
no, I'm talking about the baby
baby
side. So the height from the baby, so the surface, baby's bed surface, and the height of the phototherapy, the machine. So that's important. So if you cannot have very, means if the distance is too high, then in that case you will not be able to achieve the irradiance which you want. Okay, so you should talk about those things. Okay, and given okay, maybe was shifted to the NICU. Do you think that is essential?
Yes, sir. We should we monitor for the baby is adequately kept under phototherapy, sir. If the phototherapy is given in the ward, there is poor compliance, sir. So to prevent complete and effective phototherapy, we usually shift to NICU and we will monitor. Okay, of course, there are unit-wise differences might be there, but in general, and I think it's all risk-benefit ratio. Okay, so I would put more emphasis on exclusive breastfeeding, and I would make sure that if the baby's the bilirubin level is not nearing the exit cutoff, and it's only near the phototherapy cutoff, just above that, then I won't shift the baby. We don't shift the baby to the NICU. If mothers will easily understand, if you tell them that there is a risk of neurotoxicity, they were very unlikely to
means not key to your advice. Very unlikely. So I would take the risk. Of course, unit-wise differences might be there. The experience might be different. You might have seen more excess transmission with maybe being a but still, the default practice should be actually to keep the baby at the mother's side and start phototherapy. But make sure that it's intensive phototherapy. And tell them that actually there are studies which have compared intermittent versus continuous phototherapy, and there are studies which have shown. Means you can also if the baby is taken off for breastfeeding, and at that time you are not giving this thing, so it should not be a problem. Okay, so remember that the phototherapy works if you take out the baby for something. So actually because of the circulation, so again the equilibrium will come back. Means from the blood, whatever the blood will come back to the skin, and again it gets cleared when you start phototherapy. Within again 20 minutes for breastfeeding, it's not going to make a big difference. So the ideal practice is to have the baby at the bedside unless the level is closer to excess transfusion or RHS administration, and again is closer to excess transfusion, or the rate of rise of bilirubin is so high. In that case, I would be tempted, but otherwise we'll keep the baby at the mother's side. That should be the default practice. Palliative feeding. Why do we give? What did we give palliative feeding? Which milk was given?
So mother's milk was given, sir.
Okay, very good.
Usually
And
it
that's
has to be
good.
continued to prevent the bile stasis, sir. Even after it helps to clear the bilirubin excretion, helps in excretion.
Okay, that's good. So that's fine. But palliative feeding, the mother baby received only the exclusive EBM, exclusive breast milk.
EBM.
Okay, good. Fine. So what is if a baby is exclusively breastfed versus baby is formula fed? For whatever reasons the baby has been formula fed. What is the risk? Means, is there any difference in the incidence or severity of hyperbil in these two group of babies? So you have heard the terms breastfeeding jaundice and breast milk jaundice?
Yes, sir.
What is that?
Breastfeeding jaundice is now recoined as suboptimal breastfeeding intake jaundice, sir.
Good,
it is
very
mainly occurred due to inadequate breastfeeding, sir, which again leads to increased intrahepatic circulation, and more amount of jaundice will be appeared. Breast milk jaundice is that breast milk contains a beta glucuronidase enzyme, sir, which turns the conjugated bilirubin again into unconjugated bilirubin. Usually, the breast milk jaundice will be seen at a later stages of life. So the breastfeeding jaundice will be seen at 3 to 5 days, and once the feeding is adequate and mother is secreting.
Good, that's very good. But my question is, baby exclusive breastfed versus formula fed. So studies have shown that the babies who are formula fed for different reasons. Of course, we never recommend formula feeds, but if a baby is formula fed for some reason, for example, a mother has died, okay, or mother has some other extremely sick and is actually in the ICU for whatever reasons she was, that baby might receive formula. Those babies, actually, the rate of rise of bilirubin is not that high compared to exclusive breastfed. And those babies are also the bilirubin also the risk of the need for phototherapy also is not that high. Okay, so that's of course not all babies who are exclusive breastfed will also receive phototherapy. So that's doesn't mean that we have to switch to formula feed to reduce this thing, but just you should know that there is some this thing. There's a risk, not risk. That's this thing we are willing to take, given the immense benefits of breastfeeding. So a little bit of slightly higher risk, but that's this thing we are willing to take. And there is no question of there's this benefit towards risk. Actually, so much benefits. A slightly increased risk doesn't make any difference, and it's just not that high. So that you should know. Okay. Fine. So what about this DLPT, SLPT? So what are the
This triple 8 phototherapy and double 8 phototherapy.
And why do you do that?
Based on the serum bilirubin levels, in case of it is decreasing, we would like to change to DLPT and single 8 phototherapies.
Okay, what are the it seems that you read the 2022 guidelines of AAP. So do AAP guidelines recommend such practice? a weaning of phototherapy, sort of some in this way?
So based on bilirubin levels, we have been.
Okay, go and read about it. Okay, so there is one, of course, you 2022 guidelines, and there is actually also a technical report on how phototherapy is. So you can read that as well. Okay, so whether it's recommended or not. So you should know that. Also, when you're doing something, so you should know whether it's recommended or not. Okay, rebound bilirubin. So when do you do rebound bilirubin, and why do you do rebound bilirubin?
So there are more probability of again serum bilirubin enters the blood, and there is rise of bilirubin. So usually it is recommended at 12 hours, but it can be done even at 24 hours of life. So after stopping phototherapy, we have to check on total serum bilirubin.
Okay, good. So 12 hours for which babies, and 24 hours for which group of babies?
High risk babies usually will do at 12 hours of life. So, and 24 hours for.
In the sense, define high risk.
So any history of RH isomization or ABO incompatibility, or any history of previous sibling having required phototherapy.
Fine. So in this way, you must have done at 12 hours, and then there was normal. Okay, so maybe it's fine. Okay, go ahead. Currently day 6. Okay, sucking well. Okay, weight loss is 6.8% on day 6. Any comments on that?
So it was found to be normal, sir. It is not significant weight loss on day 6 of age.
So how much you expect? What is acceptable weight loss in a term baby?
In a term baby, it is usually 2% per day, sir. By around the day 7 to 10, the baby will start regaining the birth weight, sir, and achieves the birth weight by day 8.
Okay, 2% per day. That means 5 to 7th day, you said the baby might regain. That means you're expecting 10 to 15% weight loss?
No, sir. This should be less than 10%.
Okay, so you should know in term babies, okay, what's the typical weight loss and when do they regain, and the same way for preterm babies. So you should know that, okay? Fine, alimentation is fine. Go to the next slide. List is okay, so that's fine. So you can restrict, fine. Next.
Shall I present the examination?
Yeah.
After the getting
Sindhu, any questions?
Sir. Dr. Sindhu?
Yes, I am here, sir.
Anything you would like to add in history?
What I would like to add is on day 1 of life, by 20 hours, this baby was noted to have clinical jaundice, which required shifting to NICU and triple surface phototherapy. So that itself is a great concern because it's a very early onset of jaundice within 24 hours of life. So in such situations, doing a screening with the total transcutaneous bilirubin and then checking for the TSB, serum bilirubin, does not have any value because TCBs are, when a level exceeds 15 milligram per deciliter, you will definitely compelled to do a serum bilirubin. That's one note that I have made. Second thing is this baby required phototherapy for 5 days. That is pretty long a time for a baby. So then the second indication that it tells me that this baby has some sort of hemolytic disorder, which continue to have some hemolysis because the rate of bilirubin production has been pretty high that despite your intensive phototherapy, you are not able to control. And third thing that Jiva sir mentioned was that the separation between the mother and baby, because even on day 5 or 6, you know that the baby is not being attached properly, not latching properly. So this jaundice has also led to poor breastfeeding in the mother. These are the 3 points that I have noted in the history. Thank you, sir.
Okay, we can go ahead.
After getting consent from the mother, the baby was examined in the bed near the mother. Baby was awake and quiet, sir. Actively moving all 4 limbs. Vitals measured, temperature was 36.8 degrees Celsius, measured in the right axilla. The heart rate of 138 per minute. The regular rhythm and all pulses well felt. The respiratory rate was found to be 42 per minute. The capillary refilling time was less than 3 seconds. Saturation measured in the preductal was 98% and postductal was 98% in 2 minutes. So general examination, there is no pallor. Icterus present on face based on the trimester zone, it was zone 1. There is no cyanosis or any edema. Head to toe examination, head size was normal for gestational age. Shape appears to be normal. Anterior fontanel open, measuring of 2 into 2 centimeter. Posterior fontanel admits tip of the little finger. There is no obvious swelling noted over the scalp, no facial dysmorphism. Ears found to be normal. Eyes were normal and red reflex present bilaterally. Oral cavity, there is no cleft lip or palate. Skin icterus on the face, but no bruises. Abdomen is normal, umbilical stump is healthy, no erythema or discharge, limbs normal, genitalia, bilateral descended testis, scrotal folds developed, hips is normal, no DDH, spine is normal, no tuft of hairs was seen. So this was the new Ballard's scoring and the neuromuscular maturity and physical maturity scores of about 35, which is ranging for 38 weeks of gestation age. Anthropometry measured at birth. Weight was 2.62, the influence of 15.16, length was 47, the influence of 21.18, with head circumference of 34 centimeters, influence is 70.6. So this was the chart, and it was marked in the yellow points. Moving on to systemic examination, gastrointestinal system, the abdomen is soft, there is no any abdominal distension, no adenomegaly, umbilical stump is healthy, bowel sounds were found to be normal, nervous system, baby is awake, quiet with eyes open, which is the stage 4 Brazilian, lying supine with flexion at the upper and lower limbs, moves all 4 limbs symmetrically and spontaneously. The Bine score assessed was found to be 0. Cranial nerves, first nerves could not be assessed, second pupillary reflex is present. Third, 4 and 6th, no ptosis or squint is noted. 5, 6, 10, 11, there is rooting and sucking reflex is present. 7, no facial symmetry while crying, able to close eyes fully. 8th, now blinks or startled response to sounds was noted. 11th, now the child is able to turn its head on its own from side to side. Motor functions, posture, flexion at the upper and lower limbs, tone is normal. Power moving all 4 limbs against gravity. Deep internal reflexes was normal, plantar, bilaterally, etc. And skull and spine was found to be normal. So neonatal reflexes, rooting sucking present, armor plantar grasp present, asymmetrical tonic connective reflex present, Moro's reflex is present and is complete. Respiratory system, abdominal thoracic type of breathing, chest movements were symmetrical, there is no retractions or breath sounds heard normally, no added sounds. Cardiovascular system, first and heart sound heard was found to be normal, there is no murmur or auscultation. So this is a summary.
Okay, just go back examination. Okay. Fine. Baby was awake. So you can talk about the means baby was awake and quiet, actually moving out 4 limbs. So you can talk about the color as well. Okay, pink or jaundice. So that sort of completes that. And temperature is fine, but you should also talk about whether the peripheries were cold or not. Okay, so you can still have 36.8, but the periphery is slightly cold. So you should know. So you measure the temperature as well as you actually feel the extremities as well. So and then you should say, oh, this is normal. So when you talk about vitals for each one, you should say that okay, this is normal. So you should interpret as well. Okay? So it means you don't expect me to interpret. But it is 130 regular rhythm, multiple different, so what it is fine. So hospital is 42, which is normal for this age. So that's how you present the vitals. Capillary ripple time is fine, and saturation is fine. Anything else in the vitals? Saturation you measured. Okay. So the baby cries. So we take cry also as one of the vital signs in baby. Okay, particularly in baby with jaundice. So cry is how whether the baby is crying or not one, and whether there is actually the cry is a different type, shrill cry, or the cry is very weak. Baby is inconsolable. So that also is important. So you can add that as well as one of the vital signs. Okay. Next. Okay. So what we follow is that the general statement about the baby, and if the baby is in the NICU, then we talk about the baby's the NICU, the very paraphernalia in the NICU, and then we talk about vitals. Then we go to the gestational assessment. Okay. So that's how gestational assessment. Then anthropometry, and then general examination, and then head-to-toe examination. So even general examination, we call a special examination, which the developmental peculiarities to the newborn. For example, cephalometama, or subclinical hematoma, Epstein spots, Mongolian spots. So all those things also have to be covered. So general examination and then special examination, and then head to toe, and then systemic examination. So that's the system we follow. Systematic examination we follow. So that gestational assessment is important. And then after gestational assessment, anthropometry. Anthropometry, again, you're talking about two things: birth, and then also 2 days, because day 6 of life. This you already mentioned about the 6% weight loss. We talked about that, but here we talk about that in the anthropometry. Okay, so anthropometry is one is birth, and then we talk about the current weight, length, and the etc. are unlikely to change within 6 days, but it will be 3 weeks old. In that case, definitely we should talk about the length and the head circumference change as well. Okay, so that's important. Then fine, so balance, fine, exercise. So these are fine, so no major issues. Okay, next, go to the next one. Fine, I think that's fine. Okay. Okay, so as I mentioned, this should come up front. Okay, after vitals, gestational assessment, and then anthropometry. So on the next. So inference 15.16, what does it mean? So you're talking about the centiles. Okay, so you should tell this is the 15th centile. Okay, so weight is 15th centile, and therefore the baby is AGA. Okay, so that's important. Okay, so the chart which you're using seems to be which chart you used? Next one.
Intergrowth 21 chart we are using under your practice.
Okay, so fine. So go back. Fine, that's fine. Intergrowth chart is fine. The only thing is the intergrowth chart. The only problem is I don't know whether it's a problem, but there might be slightly overestimation of SGAs. Okay, because the bars are set too high. Whether that's applicable to Indian units, there's a controversy going on there. But if you take intergrowth as the standard, then because they're standard charts, okay, they're not the reference charts. So if you use that, then there might be slightly overestimation of small for gestational age. Okay, so that you should be aware of that. Okay, now go back. So 15th centile, and so you should say that, okay, go back. And therefore the baby is AGA. Okay, and length and the circumference are more than again more than 10 centile, and head circumference is more than 50th centile, so they are normal. So that's how we interpret. So you should interpret. Okay, you don't expect the examiner to interpret. That you should always keep in mind. Okay, then also when you talk about anthropometry, then you should talk about the current weight and weight loss in terms of percentage, and by day 6, okay, whether that is acceptable or not. So you should present like that. Okay, then you go to general examination, and among general examination, then special general examination. Then talk about developmental peculiarities, trauma, something which is peculiar, the umbilical stem, for example. Okay, so that's something which is not in any other. After 10 days, 7 to 10 days, you are not going to see even the newborn period. Okay, so you should talk about that, whether it is healthy or not. So these things should come, and then either you cover as a part of head-to-toe examination or special examination, and then head-to-toe examination, and then you go to system examination. Okay, next. Fine. Okay, next. Okay, so you don't have to elaborate too much on cranial nerves. It's very unlikely to look at major findings in particular newborns. But of course, if the baby's the case is like a baby has asphyxia, and that's your case in that, for example, case. In that case, you have to elaborate on that. So depending upon the baby's things, so you can sort of titrate. You should have examined, but you don't have to elaborate. Motor functions, so you should know tone. When you talk about tone, you should talk about both passive tone and active tone. Okay, so you should test both passive tone as well as active tone. There's a possibility that the passive tone is actually reduced, but active tone is okay, or vice versa. So you should know passive tone and active tone. So we don't use power in newborns. Okay, so we are not looking at forelimbs against gravity. So we're talking about passive tone and active tone. We don't use the test for power. Okay, then DTR is fine, plantar is fine. Plantar, again, we don't have to test because it's expected to be extensor reflex, so we don't have to do that. Okay, next. Okay, so you tested for these, and then you found them to be intact, to be there. Fine, next. Okay, so I don't see anything here. Next. Okay.
So this is the summary. 6-day-old term baby, 37 weeks plus 5 days, male, appropriate for gestational age, born to a 26-year-old pregnant mother with a nil-relevant antenatal history, delivered as inborn with a birth weight of 2.62 kgs, developed neonatal hyperbilirubinemia at 20 hours of life, required phototherapy for 4 days. Clinically, there is no evidence of hemolysis and no features of bilirubin encephalopathy. So the diagnosis will be term male, AGA with the neonatal hyperbilirubinemia, probably due to OA incompatibility, without any features of bilirubin encephalopathy and hemolysis, ongoing hemolysis.
Okay. Fine. Anything else? Yes, okay. Fine. Sundar, anything you'd like to add?
Sir, in this case, I would like to add an adjective of an early term. 37 week is an early term, and the AAP guidelines state that any baby who is less than 39 weeks has a higher risk of jaundice. So, and this baby just falls on the 15th centile. So I would like to look for features of morphological IUGR, whether there was loose skin, head chest circumference difference, loose skin folds in the thighs, whether there are any suggestions for morphological IUGR, which may again place the baby at higher risk for jaundice. And you may not say probably due to, because you have a DCT which is positive. So I would just label this case as an OA incompatibility, no evidence of binding. But what is very missing in this case presentation is what was the highest level of jaundice? Isn't it? Was it closer to exchange transfusion? Was it just above phototherapy? What was the peak jaundice? How long did it take to come down? So that particular curve and the maximum bilirubin, that is actually missing in your case presentation. So being an inborn baby, that's something that we would like to know. And you can also state whether there were any neurotoxicity risk factors. So what are the 4 neurotoxicity risk factors as per the recent AAP guidelines?
Recent AAP guidelines suggest that isoimmunization and birth asphyxia, hypoalbuminemia less than 3 grams, temperature instability, and sepsis. These are the risk factors identified.
Birth asphyxia doesn't come. It comes under the category of clinical instability. So there are only 4. Isoimmunization, sepsis, clinical instability, and having an albumin less than. Why prematurity is taken off? Because you have different charts for 35 weeks, 36, 37. So therefore prematurity is out of here. So you can state, because even in your decision making, whether the baby has neurotoxicity risk factors or not, that would decide how your decision tree. So having that would be very much useful. So what was the bilirubin in this case?
Bilirubin initially done about 20 years of bilirubin was 17.7, it was closer to the escalation range, but not exceeding the exchange transfusion range. But gradually it has come down. And before rebound, it was at 12. Rebound bilirubin, it was 12 after stopping phototherapy.
So can you define the term escalation? You said it was near escalation criteria, but not near exchange. What is escalation criteria?
After phototherapy range, that comes the escalation range. It means that phototherapy has to be intensified, and there is a role of IVAG before giving a transfusion. It helps to prevent the exchange transfusion. IVAG can be given if needed.
We'll discuss that. So if your bilirubin is within 2 milligram, it is less than 2 milligram from the exchange zone, then it is called as an escalation criteria. It is. So it is 2 milligram below the exchange number is escalation criteria. So when you are at escalation criteria, what are the things that you need to do?
if you looks for the features of bilirubin encephalopathy, and the continuous intensive phototherapy has to be given with the radiance of 30. And, serum bilirubin monitoring has to be done with 2 to 4 hours. That bilirubin monitoring should be done early when compared to phototherapy range.
So the most important thing is, first question is your unit capable of providing exchange transfusion? If so, then you can monitor the baby in your own unit. But if you do not have such an exchange transfusion facility, AAP recommends that you immediately transfer even before reaching your exchange zone. That is very, very important. Second, AAP lays strength on adequate hydration, which is oral, as well as if orally adequate is not possible, intravenous hydration is stressing. Third thing comes your IVIG. It is not routinely indicated in all cases. It is only in certain situations, like isoimmunization, especially maybe in RH isoimmunization, it may decrease the need for exchange transfusion. Okay, but not all units, when we look at evidence, it is not so clear. So it is not that every time you have to give IVIG. So this escalation point is very, very important. It stresses the need for early transfer for all those units who are not capable of performing an exchange transfusion. And when you have neurotoxicity, early features of bind, irrespective of your bilirubin, you have to do exchange transfusion. So 17 was your escalation criteria, right? After that, how long? So it was still high. You gave phototherapy for 4 days or 5 days?
On the day 1, it was still on the 17 range, ma'am. On the day 2 only, it has come down to 15. So and it was gradually reducing now after giving intensive phototherapy. But there is no drop in HB, ma'am. HB initially was 15, but later was done also, it was found to be 14.9. Not significant drop in HB, indicating no features of ongoing hemolysis.
So compared to the earlier guidelines, the 2012 guidelines, 2022, the guidelines were different. So what are the salient features of these guidelines?
2022, the guidelines as escalation range cutoff has come now. In 2022, recommended bilirubin charts. And the neurotoxicity features has been added in 2022.
Do we still follow Botany nomograms? Have you heard about those Botany nomograms, pre-discharge?
Yes, ma'am. Botany's nomogram previously was used as a range to check pre-discharge bilirubin and advised to follow based on the pre-discharge hemoglobin levels, ma'am. It has low and low intermediate, high intermediate, and high risk zones.
Are they still being practiced?
No.
No, they have been done away with. So what do we now do? WHO recommends that no baby should leave the hospital without having a bilirubin assessment. Okay, so whatever is the bilirubin, whether you can do by transcutaneous or total serum bilirubin, you plot them on phototherapy chart. You look at how far away they are from the phototherapy cutoff. If they are within 3 milligram per deciliter of the phototherapy range, the baby should not be discharged. You have to reevaluate and follow closely for phototherapy. However, if they are more than 3 milligram per deciliter, which is called as the delta or the difference between that. So we are following those now and not the bilirubin nomograms, the Botany nomograms. We do not follow. That's another difference. And you rightly said, now we have charts for 35 each gestation separately. From 35 weeks to 40 weeks, we have separate charts. Earlier, we used to club 35 to 37 and 38 and above. So they were clubbed. Now we have for separate gestations. Sir, you would like to add anything, sir?
No, that's fine. Any other comments, Marcos?
Our teacher and past president Balashankar sir is here. Sir, your remarks, please.
Shankar, Sindhu, thank you very much for accepting our request and taking this class. Excellent. Sorry, I couldn't follow the whole thing. Intermittently only I could follow as I am on the travel. So I couldn't. I will definitely watch it once again thoroughly in YouTube and definitely give my comments. Thank you very much for accepting. I hope Jiva is doing very well in ICMR. Thank you.
Yes, sir. Jiva sir is now the Director, Institute of Child Health and Development Research under the aegis of ICMR. He is the first director and I'm also proud to be his student.
Many congratulations, sir.
Thank you, Sindhu.
Proud of
You have to join.
One of the very distinguished alumni of Madurai Medical College.
Of course, sir.
And of course, Tirunelveli Medical College.
Sir, Jiva Shankar sir, your closing remarks.
I think they presented very well. For MD residents, they did a very good job. I think that's commendable. So good. Read explain a little more in depth, okay? And otherwise, fine.
Thank you, sir. Sindhu, your closing remarks.
So I would
We have your presentation also. We have your presentation regarding the students' performance.
Yes, they presented really well. The structure was very good. I would say the structure and the way that you presented, they were really good. There is a little bit more understanding for the neonatal jaundice, which comes with reading the technical report, AP technical report. It's a bit long document, but you can at least read the highlights. But both of you, did very well.
We have our Professor Srinivasan sir with us. Sir, your...
I am not a neonatologist, but Jiva Shankar was there in Jipmar, and he was such a dedicated person. I used to teach till 8:30, 9 o'clock in the evening, sitting with the PGs. I remember still. So how are you, Jiva?
I'm fine,
so
sir.
Nice seeing you. Okay, good. I remember your dedication during a few months of stay there. But of course, you deserve to be there, and in All India Institute, all the best. Thank you. And convey my regards to your wife also.
Thank you, Professor. Saishri ma'am. Saishri ma'am.
Yes, ma'am. I'm here.
Your comments.
Thank you first, Dr. Jiva sir and Dr. Sindhu ma'am for the excellent taking the young minds through the minute details of the case, which is the main lead, like one of the cause of preventable intellectual disability, which we can prevent, and a lot of preventive aspects are also there to it. Like very in detail, sir, Jiva sir and Sindhu ma'am has minute in the detail, the minute intricacies. Like we should not separate the mother and giving direct breastfeed, and all those little details are very important, to the baby and mother. And neonatology is not about, high funda ventilation and all. It is about mother and baby being together. So I think that is very nice that the young minds are getting trained under the experts, and this is very nice forum for the young budding minds to get expert opinion for their presentation. I really enjoyed it.
Thank you so much, ma'am. Thank you so much. Thank you, Jiva Shankar sir and Sindhu, for that excellent discussion. It was so fantastic. We thoroughly enjoyed. And many
madam,
congratulations
just
to
1 minute.
Yes, sir. Devendra sir, please.
Yes. It was an excellent presentation. So very good that the young ones are presenting and then the experienced ones, they are guiding them. This is a very good coordination, and heartiest congratulations to the whole of the team for bringing so good academic feast off and on. Thank you so much. Thank you for inviting also. Thank you so much.
Thank you so much, sir. Shiva, that was an excellent presentation and you answered almost all the questions. Many congratulations. I think your mentors are proud of you both. So now we'll have a short presentation on approach to neonatal jaundice by Dr. Sindhu ma'am. Sindhu?
Yes.
You can share your PP.
Okay. 1 second.
Okay, sir.
So neonatal jaundice is as common that 60% of term and 80% of preterm babies have neonatal jaundice, but it is a preventable cause of neurodisability. Jaundice deaths due to neonatal jaundice ranked 7th, and the disability has long-term implications, and it's actually preventable. Neonates are at high risk of jaundice because they have a very high load of bilirubin. Their hemoglobins are 18 or 20 at birth, and the RBC lifespan is short. Secondly, the enzyme that conjugates bilirubin, it has less activity and takes at least 2 weeks to mature. Third, newborns have less milk intake in the initial days, and enterohepatic circulation is much higher. These are the things that contribute to a higher risk of neonatal jaundice. So we have physiological jaundice, where jaundice appears after 24 hours. It has a peak level between 3rd to 5th day. The maximum is 3rd day in term and 7th in preterm babies. Generally does not exceed 15 milligram per deciliter and resolves by 2 weeks. Usually no treatment is required. However, when there is milk intake is less, or babies are exclusively breastfed, then there can be, then the jaundice levels can exceed and may require phototherapy. So this graph just shows the rate of how physiological jaundice increases and gets to lower levels by 7 days to 2 weeks. So when babies are exclusively breastfed, the jaundice levels are slightly higher because the volume of milk intake is low in exclusively breastfed babies. Some alert signs. So it is not actually pathological, but any of these alert signs, we should be reminded that it is not a simple physiological jaundice. As in this case, the onset of jaundice was in the first 24 hours of life. The rate of rise of bilirubin, if the increase is per day more than 5 milligram per deciliter, or the rate of rise per hour is more than 0.3 milligram per deciliter, or the absolute bilirubin is above 15 milligram per deciliter, then these are red alert signs that it is not a simple physiological jaundice. Whenever you have any baby whose palms and soles are jaundiced, then it indicates the levels may be above 15 or even closer to 20. Conjugated bilirubin is always abnormal, and if the jaundice persists for more than 2 weeks in a term or more than 3 weeks in a preterm baby, then also we need to evaluate them for persistent jaundice, and conjugate hyperbilirubinemia needs to be investigated. So based on when the onset is, we can have certain etiologies. For example, jaundice within 24 hours, then there is a high load of bilirubin, usually because of hemolysis. So RH, AB1 incompatibility, minor blood group incompatibility, severe infections can cause G6PD deficiency, RBC structural defects. For example, hereditary spherocytosis can have its onset early. If it appears after 24 hours, then it can be due to polycythemia, concealed hemorrhage like cephalometoma, suboptimal breastfeeding, neonatal sepsis, or metabolic errors or neonatal hepatitis. So clinical assessment. In this case, you assessed your baby and told the Kremer assessment after on day 5 or 6. Actually, once the baby has received phototherapy, there would be blanching, and this Kremer assessment will not have much role. So usually there is a cephalocaudal progression of jaundice. The people do not actually know why there is, but maybe that unconjugated jaundice has a higher affinity to the structures, especially the sclera, which has more protein. So it has an and the thin skin, higher blood supply. That may those are some theories why it appears in the head first and last to disappear from the head area. So Kremer has classified based on the know how far on the skin you feel jaundice. So you have to expose the neonate, look under in bright sunlight, and blanch the skin against bony prominence to look at the distribution of jaundice. So if it is palms and soles, obviously 18 or 20 or even higher. People also say that more than the distribution, you should also look at the color of the jaundice. So a lemon yellow versus a dark yellow, that may give some clue to the etiology as well as the severity of jaundice. So when you approach a jaundice baby, you have to look at his risk factors. Second, you have to look at the severity of the jaundice. And third, look for features of bilirubin encephalopathy. So some history, gestation, birth weight, postnatal age in hours, because all decision making is based on the postnatal age in hours. So that's important. And you have to find out whether it is an exaggeration of bilirubin, of physiological jaundice, or do you have any other etiologies, for example, hemolysis or G6PD or other etiologies. Third, you need to assess whether the baby needs phototherapy or exchange transfusion, the 4 neurotoxicity risk factors, and neurological assessment. So this is basically the assessment. Look for features of dehydration. Quantify the percentage of weight loss. So excessive weight loss beyond 10%, you may need to supplement feeding. The transition of stools, that is very, very important. So babies who have not yet transitioned to the yellow stools, even by day 5, they have a higher risk of jaundice because of increased enterohepatic circulation. And looking for other features of sepsis. So this is examination. Hepatosplenomegaly is very important. Features of bilirubin encephalopathy, you graded them based on the Bind score as well as the categories. 0 to 3 is mild, 4 to 6 is moderate, 7 and above is severe this thing. So they say that if your Bind score is 4 or above, there is a very serious problem that you may have neurological impairment. In the early stages, they may have just a shrill cry, extensor, hypertonia, hypotonia, seizures, apnea, coma, and other features are severe features. So any baby with jaundice, early onset jaundice or jaundice below the knees or thighs should have a serum bilirubin being estimated. Plot them on the phototherapy chart, decide about the intervention. So all decisions are based on total serum bilirubin. You can use transcutaneous bilirubinometer as a screening method. It can decrease the need for sampling by 30%. But any value which is 13 or above or closer to 15 need to be confirmed by serum estimation. So this is just the Bind score. It has 3 components: mental status, muscle tone, and the cry pattern. So these are the areas that are affected when jaundice levels exceed. Severe neonatal jaundice is defined as jaundice above 20 milligram per deciliter. Here you can see the subthalamic nucleus and the hippocampus being strained. Here you have the inferior olivary nucleus being strained and the cerebellar tonsils. These are features of an acute bilirubin encephalopathy. These are early kernicterus features. Between bilirubin encephalopathy and kernicterus is a chronic manifestation of bilirubin-induced brain damage. Here you can see the sunset sign and the eyes being looking down. At later stages, you may have dental enamel defects and sensory neural hearing loss. So all babies do not need estimation beyond total serum bilirubin, but when you have setting and you want to estimate the etiology, you look at the hemoglobin as you did in your case, reticulocyte count, peripheral smear, ABO setting, G6PD, DCT values. Prolonged jaundice, always estimate thyroid levels and always say mother as well as babies. Even before you refer, you have to take mother sample, which is very essential when you do a double volume exchange transfusion because you need it for cross matching. So we also discussed this that you have the AP charts. The 4, these are the risk factors for this also. I think we have discussed. These are the 4 neurotoxicity risk factors: albumin less than 3, any isoimmune hemolytic disease, sepsis, and clinical instability in the previous 24 hours. So management decisions, whether exchange transfusion or phototherapy, you use these charts. And a simple tool that you can use day to day is called the Billy tool. You have it as an app or online. Here you enter the date of birth and date of estimation or the age in hours. You write the total bilirubin, gestational age, and check whether you have any neurotoxicity risk factors. I generally put in neurotoxicity risk factors in my practice because Asian babies per se have a higher risk of jaundice. Most of our babies are exclusively breastfed and they have inadequate milk intake. So that's my usual practice to count in neurotoxicity risk factors. But that's not the usual recommendation. But what AAP says is, whenever you treat it or use any of these tools, please look into whether the baby will come for follow, whether you can arrange follow-up, and what are the risk factors in each particular case before you are, because all these charts are consensus based and not evidence based. So this is the output that you get. So they also say, if you are using a TCB, does it need confirmation with a bilirubin? Do you give phototherapy? Is it an escalation of care? Does the baby require exchange transfusion? So I have just put in a baby at 48 hours, bilirubin of 18. So it just says that baby doesn't need exchange transfusion. But yes, escalation of care you need to do. And there is a graph also that this Billy tool gives. And this is the escalation of care. So you start here. Is the baby at an appropriate location to provide exchange transfusion? Yes. If not, refer immediately. And you do all these stat labs, which include CBC, albumin, blood grouping, cross-matching, notify blood bank, arrange everything for exchange transfusion, monitor frequently. They say hydrate well, intensive phototherapy, as well as you can offer a combination of oral and IV hydration. You can consider IVIG. Okay, if you have bilirubin encephalopathy or the bilirubin is above the exchange threshold, you have to go ahead and give exchange transfusion. But it comes down when you continue with intensive phototherapy and monitor. And these are the criteria for preterm neonates. Preterm neonates do not have definite cutoff. I generally use the measles chart, or you can also use the NICE guidelines for preterm neonates. And what do you do before for normal postnatal care? This is the delta value. How far is your bilirubin, exact pre-discharge bilirubin, away from your phototherapy cutoff? That helps. If it is within 3, then you need to reassess and you may consider phototherapy also. But above that, you can very well discharge and plan follow-up. Exchange transfusion, double volume exchange transfusion removes 89% of the blood. It removes the bilirubin, but also removes the antibodies also. So that's how the exchange transfusion helps. Immediately after an exchange transfusion, your bilirubin will fall to approximately 50% of the values, but then there would be rebound because of the exchange that takes place between the tissues. So you will have to closely monitor. In case you plan to give IVIG, you have to give it after the exchange transfusion, because exchange transfusion will remove the immunoglobulins. The other thing that you also need to monitor is your albumin levels adequate, because albumin binds to the indirect jaundice. You have to evaluate for conjugated bilirubin in all babies who present with jaundice beyond 2 weeks of life. So you have certain questions to ask, whether what is the stool color, is the liver and spleen enlarged. So this is entirely a different topic, and I'll reserve it for some other day. So thank you so much, Kritika, for this wonderful opportunity today. And I thank the IAP team for giving me this opportunity with my teacher, both Jiva Shankar sir as well as Bala Shankar sir. Thank you so much.
Thank you so much, Sindhu. Actually, we are honored and privileged to have you here. Thiru sir? Thiru sir?
Yeah, I'm here. Sorry.
Thiru, neonatologist, come on.
Sir, nothing much to say actually, except that it was a very excellent presentation, both from the PGs and of course from Dr. Sindhu. So thank you very much. And it was enjoyable to watch, to listen to it, sir. Of course, as I said, I was doing something else. So in between. So I will go back and have a listen. But thank you very much for today's presentations. Thank you.
So once again, I thank Jivashankar sir for accepting. Sir, it has been an honor for all of us to have you here in IAP TNSC forum, and we are all proud of you, and many congratulations for
I
your.
can say one thing actually, Dr. Kritika was rooting for you from day one actually of when she started becoming.
Yeah, Tirunelveli product, my
she
own
literally
town.
adores you. So thank you, sir.
Thank you, Sindhu. Thank you, Jivashankar sir. Thank you, Thiru sir. Thank you, Srinivasan sir. Thank you, Rajendran sir, Narmada ma'am, and all IAP TNSC team. And thank you, Shiva. Thank you, Sai Shri ma'am. Thank you, Shruti, and everyone. Thank you all. Sir,
Good night, all of you, and once again, happy birthday to Rajendran.
Thank you, sir.